All right, Delegate Cullison, you may begin. We're live.
Okay. Thank you very much, Dylan. And welcome to the joint briefing of the Health Occupations and Long-Term Care and Health Insurance Subcommittees to discuss the topic of telehealth. This is a virtual subcommittee meeting, so I'd ask for your patience if we encounter any technological or streaming issues. Before we begin, I want to remind all the subcommittee members that this briefing is being streamed on the Maryland General Assembly's YouTube channel. Subcommittee members will be muted during this briefing. If you have a question after each presentation, type "question" in all capital letters to the chat box on the right side of your window. I will call on the delegates to answer or to ask questions. And Dylan will unmute your screen when I call on you. Even though we're meeting on Zoom, we are going to follow our usual committee rules of one question and one answer from the panel, not one question and one answer from each individual panelist. Also, please remember to keep your questions shorter than the expected answer. Today, the Health and Occupation and Long-Term Care and Health Insurance and Pharmaceutical subcommittees will hear from a variety of agencies and organizations about the topic of telehealth in Maryland. Our first panel will include Dr. Atif Malhotra, Associate Professor of Healthcare Policy and Medicine at Harvard Medical School. This presentation will be followed by a Q&A session. Our second panel will include David Sharp, Director of the Center of Health Information Technology and Innovative Care Delivery. This presentation will be followed by a Q&A session. Next, we'll hear from the Maryland Insurance Administration officials, including Commissioner Kathleen Bahrain, Associate Commissioner for Life and Health, David Cooney, and Director of Government Relations, Michael Patty. This presentation will be followed by a Q&A session. Finally, we'll hear from the Maryland Department of Health officials, including Director of Government Affairs, Webster Yee, and the Boards and Commissions Liaison, Kimberly Link. This presentation, again, will be followed by a Q&A session. Keep in mind, this briefing is scheduled to conclude by noon. Thank you all very much. And Dr. Malhotra, when you're prepared, you may begin. Thank you.
Great. Thank you very much for including me. I really appreciate it. What I wanted to do was give a little bit outside perspective outside of Maryland and think about this on a national scale, provide you some numbers that we've been tracking on the both visit trends as well as telemedicine trends. And then to kind of dive in at the end about some of the really thorny issues before all of you, as well as many other states, in terms of trying to understand both within the context of the pandemic and where we should head from here. You go to the next slide. We actually just published a report this morning, which was what we've been tracking across the country, about 50,000 different providers, where we've been following each week how many visits are they providing, in person or telemedicine? And we compare that to the baseline prior to the pandemic. And the data is through last Saturday. What we find is, and we've all experienced this, there was a just dramatic decline in the use of care into early April, a 60% decline in visits. And then a relatively rapid rebound. They kind of plateaued a bit. And then the one big thing that we've been surprising the last month or so is that the number of visits we're seeing across these providers is back to baseline. And that's in person and telemedicine. I'll divide that up in just a moment. Next slide. Before going into telemedicine, I did want to emphasize and highlight that this is, under the hood here is a lot of variation. And one of the most notable things, and I think there's a lot of concern, probably both in Maryland and nationally, is the variation by age. And we're seeing our youngest children, 0 to 2 and 3 to 5, their visit rates are much lower than baseline, about 10 to 20% lower, while among adults, we're seeing it slightly higher than baseline. What this represents, does this have a health impact, is something there's active debate right now, but it obviously is a data point that raises some concerns. Next slide. Now, the focus of the next slide, is obviously on telemedicine. And I think all of you are aware, and I'm not going to go through this full list, but there were many, many policies implemented at the federal level, I think we'll have people describe at both the health insurers as well as the state level to try to encourage telemedicine use during the pandemic, particularly early on in the pandemic, when there was so much concern that patients weren't getting the care they needed. We expanded care to patients in their homes. We waived a number of licensure requirements, and we expanded the number of providers who could provide telemedicine. There's just some examples of the changes that were made. Next slide. And the provider community responded. Again, sticking with those same 50,000 providers nationally. I'm showing you in turquoise the same line I had before, but now in orange is the drop in in-person visits. And so that gap between those two lines represents the greater use of telemedicine. And so, and if we go to the next slide, if I was to kind of zoom in on those lines, what we find is across these 50,000 providers, this is a percentage of visits during a week that are provided by telemedicine, where the denominator is the number of visits we normally see in a week at baseline. Before the pandemic, we didn't see much telemedicine use, a little bit. And then this dramatic rise up into mid-April. And then interestingly, and I think something I'll touch upon in a few minutes, as well as I think will be part of the Q&A for me and others, is this pretty significant decline that we've seen in telemedicine use across these providers. And, you know, certainly we're way above where we were at baseline, but what is driving this decline, I think, is really a big issue for the policy community and driven by regulatory and payment issues. Next slide. Here again, we see a lot of variation. We see that organizations that are bigger, kind of of course, they've had the resources, they have the IT departments to really increase the use of telemedicine. And one of my concerns is our smaller practices, those 0 to 5. They don't have that big IT department that all those resources. And not surprisingly, we see that their use, at least early on in the pandemic, was half the rates that we saw for the bigger organizations, your Hopkins, et cetera, University of Maryland. Next slide. And this is last week's data in terms of the use of telemedicine, differences by specialty. And, you know, the key thing that pops out, obviously, is the behavioral health providers, our psychiatrists, our social workers, our psychologists. They are using telemedicine for more than 40% of their visits. And then for other clinical areas, we see relatively little use. In particular, not surprisingly, for some of our surgical subspecialists, it's kind of hard to do an ophthalmology appointment via telemedicine. And so, but I think it's important to recognize that, and I'll highlight the primary care and the pediatricians who are sort of in the middle there. Next slide. We also see substantial geographic variation. So these are data a little bit differently. These are the first 12 weeks of the pandemic. And what we're showing you here is we've broken up all the counties in the United States by their telemedicine use. The ones in white, we just didn't have enough patients. So, but if you focus on the shades of green, you'll see that there is substantial variation across the country in their use of telemedicine. And I'll obviously highlight Maryland up into New Jersey, New York, Massachusetts. These are the areas of the country where we're seeing the greatest use of telemedicine. And in contrast to some of the other areas, maybe more rural areas of the country where we see less of it. Next slide. I think one of the points of concern, I think it'll be an important point of debate, is that while, okay, we've looked at telemedicine, but how does this vary by socioeconomic status? And are there communities that don't have the access, the digital access, which is basically a computer or a smartphone, to be able to do a video visit? We looked at some data from a couple of years ago among Medicare beneficiaries. And not surprisingly, about half of those, just over half of those who are whose income was less than 100% of the poverty line, didn't have access to one of these tools. And as your income increases steadily, the access to the more and more people have access to those. We also see, very importantly, differences by race and ethnicity. And those, obviously, these are the kind of data that really raise concerns about access to video visits and is informing that debate about should audio only visits, a fancy way of saying a phone call, should that be a part of the reimbursement structure and regulatory framework as we move forward? Next slide. So I want to, in the last couple of slides, just emphasize now turning to the really difficult and thorny issues of what should the payments look like and what should the regulations look like for both telemedicine during the pandemic and also post the pandemic. Next slide. So I first wanted to start with some really high level thoughts, and then I'll go into some of the details. High level, the first thing I want to emphasize to all of you is there's an urgency in determining post-pandemic policy. I highlighted for you that practitioners from across the country are abandoning telemedicine. And in part, that is driven by the uncertainty about what will things look like post the pandemic. Early on in the pandemic, it was telemedicine by desperation. You did whatever you could to try to do a video visit or a phone call with your patients, and it was a lifeline for so many patients. But now providers are in a different position where they're thinking about strategically, should I invest the dollars into the technology, the training of my staff? Should I change my clinic workflows, et cetera? And that's a big investment. They just went through a really rough time financially. You're not going to make that investment if you don't know in 2 months, 3 months from now, that investment won't bear out. And so in many of them, they're right now, given that uncertainty, they're choosing to pull back and say, look, let me go back to tried and true, what I know is in-person visits. And we have, given that pandemic and the rates of COVID cases that are rising, I'm not sure that's what we want. We'd prefer, I think, in many cases to encourage telemedicine to keep our residents safe. However, I want to recognize at a high level that government, both at the federal and state level, as well as commercial health plans, are worried and leery of making these broad expansions of telemedicine permanent. And they're highlighting a very complex issue, which is that the convenience, which is the real benefit of telemedicine, also could be viewed as its Achilles heel. And specifically that, at least under a fee-for-service system, something we'll come back to in a moment, that there will be overuse of telemedicine. In other words, telemedicine that's not improving health. What do I mean by that? I mean, well, Mr. Jones, why don't we just check in on your lab tests in a couple of days and we'll just do a telemedicine visit? Or, well, you're doing pretty stable on your hypertension, but let's just check in with you every week or two just to make sure things are okay. These are examples you can understand why they might go and use those types of care, but you worry that this will increase utilization and increase spending. And obviously, both in Maryland and the rest of the country, we're worried about that. So let me end by going in the next slide by a couple of key policy considerations that I'm hearing both at the federal and state level that people are considering, and give you my own beliefs on what I think ways that you might move forward. The first thing I do want to emphasize to you is that telemedicine, almost all of the conversation and debate is about video and audio visits because we pay for them. But I do want to recognize that there's a lot of other forms of telemedicine or telehealth that are being used out there that aren't being paid for, and we're not talking about it. And so give an example of that, roughly almost 1/3 of Americans have signed into their patient portal with their doctor's office and messaged their doc, Dr. Smith, I'm worried about X, Y, or Z, and the doctor responds using that asynchronous portal. We don't pay for it, so we don't talk about it, but it's a really critical way, and the use of those portals have surged through the pandemic. The second point I want to emphasize to you is that we have to think more broadly about telemedicine, not have a single telemedicine policy. If I went to a health insurer and said, what's your drug policy? They kind of chuckle like, what do you mean? Which patient, which drug? What's the clinical circumstance? And I think we need to be thoughtful about that with telemedicine. Our policies might be very different for the use of telestroke in the emergency department versus telemedicine via an app for a viral upper respiratory illness. And so how do we reconcile that? The third point I'll emphasize is that other thing is that when it comes to telemedicine, we need to think much more broadly than our individual states. when telemedicine providers before the pandemic, when we asked them, providers in general, why aren't you using telemedicine? Many of them would say, I just can't figure it out because I'm trying to practice across 4 states. They each have their own regulations. And then I got 30 health plans and I got the federal thing. And then I got 4 different Medicaid programs. And that complexity and that labyrinth really made it very difficult. And you can understand why a lot of people would throw up their hands and say, I'm just going to go take care of patients in my clinic. And so another key thing is as Maryland is thinking about its policies, to what degree do they echo the policies of neighboring states as well as on the federal level? That's going to really help a lot in terms of facilitating telemedicine if that's what you want to focus on. The next point I'll emphasize is that there's a lot of debate at the federal level about when providers are at risk, in other words, they're getting global payments or ACO contracts. Why are we worried about this? Let them use telemedicine as they see fit. And everyone points to Maryland and says, well, Maryland, let them use telemedicine because of the very innovative ways that you have implemented global budgets. And so I think that is another thing, that you could have a very different policy under such a one payment model versus another payment model. At least that's how the feds have been thinking about it. If there is going to be a fee-for-service component of this, then there's the question of how do you limit these overuse? And at the federal level, they've been thinking about it from the patient or condition or provider level. For example, before the pandemic, the feds only allowed for telemedicine for rural patients, except for the treatment of substance use disorder, which they allowed for everybody, so condition specific. And also in some cases said certain types of providers can provide telemedicine. And then I'll end by just highlighting a really other thorny issue, which I think some of the other speakers will also touch upon, is do we pay, if we pay for these visits, do they pay it at the same level as an in-person visit? And do we pay for the phone calls? And I'll just give you my own beliefs on this. I believe that for audio only visits or phone calls, that while I recognize they've been a lifeline for some of our underserved populations, I'm also cognizant that in many cases, the video encounter is really important. So my belief is that we should have a short-term 2 to 3 year time horizon where we do cover audio only visits and use that time horizon to make sure we get the technology to our disadvantaged populations and train them and train our providers so that they can provide the type of care that I think is really necessary. But I don't think that we should have a 2-tier system indefinitely where the poor only get audio only visits. And then lastly, and I know many people will disagree with me on this, is in terms of the payments for these telemedicine visits, I believe they should be paid less than an in-person visit. Because while I recognize there's investments that need to be made over the long time horizon, they should be cheaper, and therefore the payment should reflect that. A lot of ideas there, but I hope they're helpful for you as you move forward in addressing these thorny issues. I know other speakers will touch upon those same issues in their talks, but let me stop there and see if there's any questions that I can answer for you.
Thank you very, very much, Doctor. This has been tremendous information. I really appreciate it. I am not seeing any questions in the chat box. Delegate Kelly, do you have any questions?
Thank you, Delegate Collison. I just wanted to follow up and see if you could expand a little bit on the last point that you made about payment parity and talking about, I thought it was really interesting the way you talked about both the audio only visits and maybe looking at a 2 to 3 year time frame. And then also in terms of the payment parity, can you just walk me through a little bit more what that might look like, looking at a future where it should be cheaper and payment should reflect that, but maybe we're not there yet?
Yeah, so let me kind of highlight or clarify some of my thinking. So a doc might come to you and say, look, when I do my telemedicine visit, I spend 15 minutes. And when I do my in-person visit, I spend 15 minutes. So why would you pay differently? Yes, but it's not when we pay a provider for an outpatient visit, we're not paying just for her time. We're also paying for the rent, the overhead, the medical assistant, that really horrible gown that we make patients wear. You know, all of those costs go into that visit. And so therefore, because telemedicine allows us to reduce those overhead costs, that's why I believe in the long term, it's going to be less costly for a provider. And therefore, the payment should reflect that. Now, one last point that is I hear from a lot of providers, well, yeah, that's fine, but I got to put a lot of money right now to invest in that, to build up that infrastructure. And I would go back to the same way as an MRI machine, right? When University of Maryland buys a MRI machine for $1.5 million, they put a lot of money into that. And then over the course of 10 to 20 years, they recoup those costs. And that's the same way we need to be thinking about it in this circumstance. So those are I don't know if that clarifies, Carrie, what my thought process is.
It really does. Thank you so much.
Thank you, Delegate. Thank you, Doctor. Delegate Lewis Young, would you like to ask your question?
Sure. Can you hear me?
I can.
Good. I've had about 3 telemedicine visits since March, and they were all very effective, and I was pleasantly surprised. They were appropriate and effective. You know, can we design policies that will address the 3 to 5% of the population that will abuse the system? Because on any medical issue, there are always going to be outliers. So do we address the policy to the general population or to the exceptions?
I think you raised an important point. One area where the exceptions come up is, and I think it's important to focus on, is the issue of fraud. We have concerns and some experience already, unfortunately, where providers have used telemedicine to try to pump out direct medical equipment, for example, walkers, et cetera, obviously very inappropriately. And I think I would echo your thoughts, which is that while we think and those issues are important, we don't use those as the way to guide all our telemedicine policy. It just means that we may need to ensure that we make those investments to address that kind of fraud. We have to recognize, let's not be naive with this, that these things will happen, but we just need to put the investments in those. And some of that's going to be at the state level, but unfortunately, also a lot of that's going to happen at the federal level also. And certainly Medicare and the Congress are worried about this particular issue.
Thank you.
One thing I might highlight that I don't know if gets discussed enough, I apologize for interrupting here, but your question, when you said you had a very positive experience, I do want to also highlight something that I didn't mention with the audio only visits, which is the patient response. I'm not saying for all patients, but I have been hearing some complaints from patients about paying for phone calls themselves. So if they have a high deductible plan or out-of-pocket cost. And you can understand it, which is that before the pandemic, you called Dr. Jones, you said to him, I got a problem. They answered it, your phone call, you were done, you clicked, and that was great. It was free. And now all of a sudden you have the same 5-minute phone conversation, you get a bill for $120 and you're like, and you can understand why patients could be quite upset about that, in particular, if they're paying that $120 out of their own pocket. I can understand the perspective of the physician who says, look, it's my time, I need to be paid for my time. But when you got something for free before and now you have to pay for it, you can understand. So I just add that one anecdote. I'm not saying all patients are like that, but as you think about how to implement those policies, be cognizant of that potential little bit of backlash that you might face.
Thank you, Doctor. Delegate Krebs. Delegate Krebs.
I unmuted, thank you.
There we go.
I'm not worried as much about the abuse as I'm worried of the system as I'm worried about the appropriateness of a telemedicine visit. And I look at certain ones, I believe 100%, it's wonderful. Things like cardiology, picking up on things in a visit that you might not pick up on over the phone. And it seems like it's so varied. How do we ensure that we're not, think of a cardiology follow-up. How do you follow up with cardiologist over the televisit? So how do we make sure that we're not missing out on things that would be picked up in a real visit when we're constantly doing telemedicine with the same patient?
So first, I want to emphasize to echo what you're saying, Delegate Krebs, that there is variation, that while there is a lot of evidence that in many clinical circumstances, a telemedicine visit is of equal quality as an in-person visit, we should not expand upon that and say, well, then all telemedicine is appropriate in all clinical circumstances. Some of that is obvious. We also have done some research highlighting that in some clinical areas, telemedicine is inappropriate. For example, in the diagnosis of ear infections in a kid. How are you gonna like figure that out with a wiggly 3-year-old on mom's lap, whether the kid has telemedicine, an ear infection if you can't look in the ear?
But how do we do that policy-wise? Do we leave that up to the professionals? I mean, as we're crafting policy, how in the weeds do we get on this as we move forward?
Yeah. And there I would then go to the next step and say that I think at a state level or a policy level, that would be almost impossible for you to set up policy that you would specify you can use it for this and you can't use it for this. And in that particular case, I believe it is back to the professions and our malpractice structure to enforce that we use professionalism and that structure to ensure that we're providing the right care. And the reason I bring that up, Delegate Krebs, is that it's very complicated. For example, I gave you that example of the ear infection, but if the mom has a digital otoscope that she can put in the kid's ear, that visit may be just fine. You brought up the cardiology appointment, and a lot of cardiologists are very concerned about doing follow-up visits via telemedicine because they don't have an EKG machine. And that's a pretty important thing in some circumstances. But now people have smartphones with EKG machines. So you can all of a sudden take an unsafe to a safe. And I don't think that at the state level, you can make that level of specification. And therefore, that's why I believe it's back to the professionalism as well as the malpractice system to address where and when it should be used appropriately.
Thank you.
Thank you, Doctor. Dr. Kelly, Doctor, I just changed your profession, Delegate Kelly. Better follow up.
That is my lifelong fantasy that I will never fulfill. Thank you, Delegate Cullison. I'm sorry, I know we have one question, one answer, and I had a follow-up to my original question, so I apologize. But when you showed us the original, I think it was on the second or third page of your presentation talking about utilization by specialty, the behavioral health was at 40%. So I wanted to know if you could expand a little on why you think that is, and if they need different rules. You mentioned the feds cover substance use at a different level. You know, do you see a different model for behavioral health, or do you see one size fits all? How can we make sure that people who need behavioral health treatment are getting it? We have been looking in Maryland in particular about making sure that we're complying with parity laws, and we have work to do.
Yeah, so it's a really important point. So first, address the question of why behavioral health providers have embraced telemedicine more than other specialties. First, I should emphasize prior to the pandemic, when we were looking nationally, the vast majority of the visits were also for behavioral health. And so I think one aspect is there's a lot more comfort level within that specialty as opposed to many other areas where their first use of telemedicine was in April of this year. The second thing is just clinically, it's much more suitable to telemedicine because the need for the physical exam, as well as laboratory testing, et cetera, is just less than you need. Not saying that's never needed, but is less of that. And so I think that also that the clinical encounters, and then the last point I'd emphasize is there's a lot more evidence in behavioral health that it is an effective modality. So I think the combination of all those factors led to the very substantial rise in the use of telemedicine, greater than other areas, and also, as I showed you for last week, still substantial use for that. Your second question, Dr. Kelly, excuse me, is to, sorry, I couldn't resist, was the issue of should you, state of Maryland, treat behavioral health differently than other areas? If you decide that there are need to, in the piece that I kind of highlighted on the screen, I advocated that the telemedicine in the area of behavioral health is an area where I think there should be broad expansion, because I do think it should be the exception, both because there is such a shortage and a lack of supply of behavioral health providers, and if this is a way that we can move forward. I also think to some degree that it would be very difficult for us to go back in behavioral health, because it is, the cat's out of the bag here.
Thank you so much. I appreciate that answer.
Thank you, Delegate. Thank you, Doctor. I do have one brief question. I am intrigued by this notion of, having to look at a broader area. And so I'm wondering if you have any sense, Doctor, that at the federal level, they're beginning to look at some guidelines around telehealth beyond the, beyond Medicare, but, in general, or if this is, you feel like this is really going to be left to the states.
So to date, it has been very much under our federal system that the states have been given tremendous deference in terms of developing policies. So certainly on the federal level, there is limitations on what they can do. And again, it does come to state by state. I think the one area that I might highlight where I am seeing substantial interest within the Congress is regarding licensure. There is frustration at the federal level, and I think among many providers, that state licensure boards have restricted the ability of other providers to come in. And as you're well aware, the Federal Trade Commission is very concerned that this has been decreasing competition within states, because you don't limit, I can't provide care at Harvard to a Maryland resident easily, because it's just very complicated with the licensure system, and the interstate compact doesn't work that well. And so that is one area at the federal level that I am seeing potential interest, which is how can they encourage states to do reciprocity across state lines. So Maryland would say that any physician or other practitioner in other states who is licensed and in good standing in those states can provide care to Maryland residents. And so that is one area that I think there is a substantial interest. I would encourage you within Maryland to consider those kinds of regulations, because I do think they would be effective in terms of encouraging telemedicine use and giving Maryland residents more options. We were talking about behavioral health. If a patient, a Maryland resident, can access a psychiatrist in other states, that's going to give that patient a lot more options.
Thank you. Thank you very much, Doctor, for your time and for your very comprehensive and informative presentation. I appreciate that. I don't see any other questions, so we're going to move to our second panel, which is David Sharp, the Director of the Center for Health Information Technology and Innovative Care Delivery. David, are you there?
Can you hear me? Can you see me?
I can hear you, and I think I'm seeing your slides, but I don't see you particularly, but it could be just not visible on my screen.
Okay. All right. Well, I will start off, and if you need me to pause why there's some technical adjustments, just let me know.
Okay.
I would begin by applauding Dr. Marotras on his presentation. An excellent presentation, I think, that summarized well at the national level some of the challenges related to telehealth. My presentation today will be more state specific in what we see here in Maryland, which to some extent are challenges and opportunities that are shared more broadly nationally. So to begin with, good morning, everyone. Again, for the record, my name is David Sharp. I'm the Director for the Center for Health Information Technology and Innovative Care Delivery at the Maryland Healthcare Commission. It is my pleasure to present to you all today on behalf of our Executive Director, Mr. Ben Steffen, who could not be available today and sends his regards. Joining me to answer your questions is Ms. Megan Renfrew. She's the Director of Government Relations and Special Projects here at the Maryland Healthcare Commission. Next slide, please. The MHCC identified telehealth as a strategic priority in 2018. The Commission views that assessing barriers to adoption and proposing solutions can lead to expansion of telehealth, lower healthcare costs, and improve access to care. The MHCC promotes telehealth adoption and meaningful use as a way to meet patients where they are and remove barriers to care. Education and awareness is key to advancing the use of telehealth. Telehealth is particularly helpful for patients in rural locations with limited mobility or with minimal access to transportation. Next slide. Some leveling off of telehealth has occurred since the peak. However, it remains above pre-pandemic levels. Providers are now taking a holistic look at their operations and their health information technology systems, and where possible, they are adopting processes to optimize their workflows and the capability of technology in an effort to reduce cost, improve care delivery, and enhance the patient experience. The MHCC is planning to conduct an impact evaluation of telehealth adoption in 2021 that minimally includes access to care, leading professional services delivered using telehealth, whether telehealth has created new demands or is a replacement to in-person care, as well as impact on emergency department utilization. Next slide. This slide illustrates key telehealth policy changes as a result of executive orders and federal waivers. As you may recall, Governor Hogan issued a number of executive orders relating to telehealth coverage expansion that enabled more providers to use telehealth and tweaked the rules to allow out-of-state providers to use telehealth to treat existing patients in the state. CMS launched several emergency initiatives that expanded Medicare and Medicaid coverage, including increasing the types of providers able to use telehealth, allowing providers more freedom to use different modalities, such as remote patient monitoring and telephone-based services, and expanding the number of sites qualifying for coverage, such as a patient's home, federally qualified health centers, and rural clinics. Next slide. Almost all payers reduced or eliminated cost sharing. In addition, on March 17th, the Office for Civil Rights at the U.S. Department of Health and Human Services announced effective immediately that it will exercise its enforcement discretion and will waive potential penalties for HIPAA violations against providers that serve patients through everyday communication technologies during the public health emergency. This exercise of discretion applies to widely available communication apps such as FaceTime or Skype when used in good faith for any telehealth treatments or diagnostic purpose, regardless of whether the telehealth service is directly related to COVID-19. Next slide, please. This slide provides a snapshot of telehealth adoption prior to March. For the most part, adoption has occurred slowly over the last decade, and its use was minimal prior to the pandemic. The reasons vary, however. They can be attributed to payer reimbursement policies, workflow challenges, and patient and provider concerns related to privacy and security. Next slide, please. Telehealth diffusion increased dramatically in response to COVID-19. This slide provides estimates on the numbers increase in adoption by provider type. Providers in general have done a laudable job rapidly implementing technology to support care delivery during this public health emergency. A report was released by McKinsey in May stating that providers nationally are seeing 50 to 175 times the number of patients via telehealth than they did prior to COVID-19. Next slide, please. Okay, and next slide. In April, MHCC launched a telehealth virtual resource center webpage to help educate and provide resources to providers implementing telehealth. The webpage contains several web-based tools, such as a telehealth readiness assessment tool, which has received nearly 2,000 hits since April, and a telehealth technology vendor portfolio that includes over 75 vendors with information on HIPAA compliance, business associate requirements, and vendor user ratings. We continue to add information to this webpage to build awareness and promote effective use of telehealth. Next slide. Staff has also developed telehealth education and awareness material for consumers, such as information-based flyers, podcasts, and PSAs. This information is available on MHCC's consumer telehealth webpage. Planning is underway for additional PSAs and podcasts. It's worth noting that since April, staff has responded to about 100 inquiries related to telehealth. Next slide. 3 MHCC state designated management service organizations were awarded technology grants in April to diffuse telehealth in practices. The MSOs are focused on diffusing telehealth in practices that are reluctant to adopt technology absent technical assistance. The grant provides MSOs with milestone payments for completing a telehealth readiness assessment and addressing gaps, restructuring workflows, educating on payer use policies, and training staff on how to use the technology. Next slide. Payers and policymakers are beginning to contemplate where we go from here. Few would say that a return to pre-COVID-19 is a welcome return to the past. Payers have signaled that some lessening of existing policies are likely to occur at the end of the public health emergency. These policy areas include the use of audio only, whether payment parity for telehealth should continue, and budget considerations for the Medicaid program. Included in all policy discussions is the need to address inequities in access to telehealth. Next slide. Staff invited diverse stakeholders to participate in a telehealth policy work group to review policies temporarily implemented in response to COVID-19 that ought to continue after the public health emergency ends, identify potential opportunities to collaborate on future legislation, and assess stakeholder plans to introduce telehealth legislation in the upcoming session. An information brief is targeted for release in early 2021. Next slide. Okay. Members of this committee, this concludes my presentation, and Ms. Renfrew and I are happy to address any questions from committee members at this time.
Thank you very much, Mr. Sharp. I appreciate, again, the very thorough information. We'll open it up now to committee members for questions. While folks might be thinking of question to put in the chat, I'm going to ask one. I have been very interested in expanding the accessibility and use of school-based health centers. And I was pretty disappointed this year when all of those centers were closed down because schools closed. Seems to me that one of the ways we could have continued to use them was through telehealth. Would you be supportive of us, figuring out ways to make sure that that happens, that can be facilitated? Should there be, even now as schools continue to be closed, and in the future, should there be a need to close schools down?
So Delegate Collison, that's a great question. I would also encourage my colleague, Ms. Renfrew, to join in this answer. About a year ago, we were asked by the HGO chair if we would convene a work group related to school-based telehealth and make some recommendations. Excuse me, that letter actually came from the Senate Finance chair. And we convened stakeholders, we developed a report. Essentially, we identified a number of areas in which school-based telehealth could be advanced in the state. Typically, for the commission to support legislation, that's a decision made by the commission itself. But I think that we've seen from our commission that there's been a lot of support around advancing school-based telehealth. So I would imagine there would be a great sense of openness to collaborate with or support the legislature on recommendations. Megan, your reactions or thoughts?
Just that we'd be happy to get you a copy of that report, Delegate Collison, if you would be interested in that. Happy to send that your way.
I would very much appreciate that. Thank you.
No problem.
I don't see any other questions in the chat box. Wait a minute. Delegate Lewis Young, you have a question or a comment?
Well, it really wasn't a question, but I can turn it into one. because you made a great point about the mental health centers or the health centers in schools. What I am finding from my constituents is that those students that are either suffering from mental illness or they have a learning disability that's related to mental illness are suffering disproportionately in a virtual learning environment. So either would this be one of the solutions? What other things can be done to address the special needs of those students? I'm seeing an emphasis on getting students back to sports, and I feel that these children struggling in this environment aren't popping up to the top of the list of the needs that we need to address.
And so that too is a terrific point, and a great question. I would call out that there are school-based health centers which are run by nurse practitioners or physicians and a small staff in the state. There's also school health nurses or school health services, which typically include a registered nurse or an LPN that either are site specific or have several sites. And during this pandemic and with remote learning by students, these health nurses, if you will, have been filling the gap because they are working with students and their families via telehealth. And we've done some education and awareness on best practices for using telehealth for school health nurses because historically that has not been a technology or approach to supporting care delivery via the students in a remote environment. So there's lots of run room there for innovation around technology to help students in these remote settings and also help the families, because the families are, or the guardians of these students play a pivotal role in, as you mentioned, the behavioral health. So I think there's great run room. It's something we should consider and look to explore. And maybe that's something Delegate Cullison is thinking about as well with the school-based telehealth.
All right.
May I follow up with a very quick question that's related to that?
Sure, Delegate.
Do those students need to have an IEP in order to qualify for that service? And if so, is anything being done to expedite the approval of the IEP process?
So the individual education plan is not required in order for the services to be provided by the school health nurses or the school health center. So while many students have those plans, it is not sort of a barrier to entry to care delivery, if you will.
Thank you.
Okay. Delegate Kelly, you have a question?
Thank you, Delegate Cullison. I just really want to thank you for this informative presentation. I wanted to follow up and just repeat what I think I heard you say so I make sure I have the timeline right. You all have been convening the telehealth policy work group. It's meeting regularly, and we should be expecting an information type policy brief from you guys sometime early in 2021.
So hopefully I didn't overstate it. We convened a diverse group of stakeholders. We probably, at the first meeting, which was just last month, we had nearly 70 stakeholders participate remotely. So we are meeting again next week. We're meeting again a couple more times between now and the end of the year. We are narrowing down the scope of what we would call policy discussion areas because the list is far ranging. And we want to hit on areas that we can get some consensus around that are most important to the group, and then be able to make some recommendations on policies back to the legislature and other stakeholders. We are on target at this point for having an information brief early in 2021. If the work group gets snarred down in any of the policy discussion areas, it could slow us down a bit, but we'll work hard with these 70 odd stakeholders to try to keep the wheels turning and moving and momentum going.
Well, and I just really want to reiterate my appreciation for that. I know it's not easy. It's a lot of work, and I think we appreciate that. And I want to make sure that the committees, to draw their attention to the appendix at the end of your presentation. You didn't have time to go through all your slides, but that appendix is really detailed. It has a lot of really interesting information about different policies and payer policies and things like that. So it's a ton of work, what you guys have been doing, and very much appreciative.
Thank you, Delegate Kelly.
I don't see any other questions. Thank you so much, Mr. Sharp, Ms. Renfro, for your information. And we look forward to the information you're going to bring us early in 2021. Thank you. So we're going to move to our third panel today, which are representatives of the Maryland Insurance Administration, including the new Commissioner, Kathleen Bahrain. Welcome, Commissioner, to your first subcommittee meeting. I know that you've been in a full committee meeting. Associate Commissioner for Life and Health, David Cooney, whom we've seen many times, and Director of Government Relations, Michael Patty, another frequent visitor to HGO. And again, this presentation will be followed by a Q&A. So I'm going to turn it over to the Commissioner. Commissioner, are we there?
Am I unmuted now?
There we go.
Okay. Well, thank you. Thank you for that welcome and for the opportunity to provide an update on telehealth coverage in the Maryland commercial insurance market. The telehealth coverage requirements for commercial insurers is set out in section 15-139 of the insurance article. If we could go to the next slide. We summarize some of the critical points sort of where we are from a legislative statutory perspective. Carriers are required to cover all otherwise covered services that are quote unquote appropriately delivered through telehealth. Telehealth is very broadly defined as the use of interactive audio, video, or other telecommunications or electronic technology by a licensed healthcare provider to deliver a healthcare service within the scope of practice of the healthcare provider at a location other than the location of the patient. That's a very broad definition, but the statute does specifically exclude audio-only telephone conversation and electronic messaging. So the kind of patient portals that Dr. Malhotra just described, those are excluded from the definition, which means they are not required to be covered. The next slide, please. Carriers are not required to reimburse a healthcare provider who is not a covered provider under the insurance contract. Carriers are permitted to apply cost sharing for services delivered through telehealth, and they are permitted to perform utilization review to determine the appropriateness of the telehealth service. The MIA also has the authority to review denials for telehealth services that are not deemed medically necessary, appropriate, or efficient by the carrier. And the current statute does not address parity. So what we have seen is that at the MIA, as we've tracked this with health insurers, is that the pandemic has led to really an exponential growth in telehealth utilization. We've closely tracked use and coverage issues related to it, including accessibility, reimbursement concerns by healthcare providers and consumers, and accommodations that have been made by health insurers to cover telehealth services outside of what the statutory law requires. And David Cooney is really going to share with you the results of our most recent survey of telehealth use, what our analysis is of the key issues and what the MIA's response has been to date. And then I'll come back to talk about some lessons learned. So David, if you can take the next slide, that would be great.
Sure. Thank you, Commissioner. As the Commissioner mentioned, I'm going to try to briefly talk about really how the pandemic impacted both availability and utilization of telehealth in the commercial market. And I'd like to start off here with this kind of visual representation of the exponential growth that we saw in telehealth utilization by covered members once the pandemic hit. So we surveyed the 5 major health carriers in Maryland and asked for claims data on telehealth utilization for encounters in the insured market pre-COVID and throughout the pandemic. So this slide and the next slide are 2 graphs showing that. This first one has all 5 carriers in the same graph. I think this one's more helpful to see the overall volume of telehealth utilization, whereas when we get to the next slide, we split out the carriers separately. I think it's easier there to kind of see the trend for each of the carriers. So if we go back to the prior slide for a minute, I do want to mention there were some data limitations here due to the short turnaround time. A couple of the carriers weren't certain that they said it was possible some of this data may have included some of their self-funded business. A couple of the other carriers indicated that it may include some regional customers outside the borders of Maryland. But so these numbers might be inflated a little bit, but they all clarified that the trends that we see here would be consistent regardless. So if you can see, that first column is the pre-COVID numbers. You can hardly even see anything there because the increase was so substantial after that. But what we saw is the carrier with kind of the lowest amount of telehealth utilization prior to the pandemic, they had about 470 encounters each month, whereas the carrier with the most had about 920 each month. So it's kind of an average per carrier of about 719 visits. Once we got in March, when the pandemic hit, we increased where the average number of visits was up to over 13,000. The high carrier had about 32,000, the low about 3,400. And then once we got into April, when really the peak of the pandemic started approaching, you see the tremendous increase we have there, where the average number of telehealth visits was up to almost 48,000. That green line there, that particular carrier, they had over 107,000 telehealth encounters just in the month of April alone. May, the numbers were similar. The average had increased to about 54,000 per carrier at that time. And then after May, it started to decrease slightly from June, July, and August. The carriers didn't have the September data yet, and a few didn't even have August. But even at the end there, by August, the average was still around 45,000 visits per carrier. And I think it's important to note that one carrier, Carrier 2 on this chart here, they pointed out that between March and May, 85% of their encounters were virtual. By June and July, they remained steady, about 50% in person, 50% virtual. And of those virtual, 25% were video and 25% were audio only. All right, if we could go on to the next slide now. Here, just to see the trend overall from carriers, I think it's interesting to note, if we compare the pre-COVID levels to the most recent data we have in August, if you look at Carrier 1, it's an increase 35 times the number of telehealth visits that they have in August compared to the pre-COVID levels. Carrier 2 did not have their pre-COVID numbers available at this time, so we couldn't really compare there, but you can see the trend in the chart. Carrier 3, it was a 76 times increase from pre-COVID to August. Carrier 4, 52 times, and Carrier 5, 26 times. So we're not really sure yet, of course, what the new normal is, but I mean, across the board, all the carriers acknowledge there's no way that we're going to be returning to the pre-COVID levels, and a lot of this increased utilization is here to stay. So there were several factors that contributed to the growth in telehealth here. I mean, on the one hand, it was, the fear and caution over face-to-face encounters that we've discussed previously, from both patients and providers, and related concerns about mitigating the spread of COVID-19. But it is important to note that some of the changes that have been discussed previously and that were made at the federal level, they were really critical in allowing this expansion to happen. Particularly the Office of Civil Rights Enforcement discretion related to HIPAA, which was mentioned previously, and some of the CMS guidance and waivers that applied to Medicare and Medicaid only, but it really kind of drove the changes more broadly across all markets. So the next two slides we have here, they describe the carriers' responses and the MIA actions related to telehealth. And I'm going to go through them together because these items really went hand in hand. At the beginning of the pandemic, when we're thinking about telehealth, the first thing the MIA did, we examined and reevaluated the requirements under existing law to determine really how the law should be interpreted in the context of the pandemic, because certainly certain types of care that maybe didn't appear medically appropriate via telehealth in a normal context, that the determination that really kind of changed in the situation of a pandemic. So we considered what our options were with our emergency powers. We didn't really see where we necessarily had authority to require significant changes. But so in our first COVID-related bulletin that we issued back in March 6th, which was a bulletin 20-05, We asked all the carriers to encourage their members to utilize telehealth services wherever appropriate. And then from that point forward, we maintained open communication with the carriers as the pandemic progressed, and we advised them of all the emerging issues we became aware of related to telehealth. Healthcare providers, consumers, and advocacy groups contacted us with a broad range of telehealth-related concerns and requests, and we communicated those issues with the carriers. We, of course, ensured carriers were complying with the existing law, but we also encouraged the carriers to accommodate any kind of reasonable provider and consumer requests in this area. And the response from the carriers was extensive telehealth-related accommodations in the commercial market, which they were not statutorily required to do. Some of the first concerns we heard were really from providers concerned about the limitations on the capacity and accessibility of the carriers' existing platforms. And once the Federal Office of Civil Rights announced their enforcement discretion for the HIPAA requirements, carriers pretty much immediately all expanded the telehealth systems that would be eligible for coverage to include any non-public facing commercial platforms, things like FaceTime, Skype, and Zoom. And that really enabled telehealth to be much more accessible. We then started receiving a lot of requests from consumers and providers for a broader scope of services that should be eligible for coverage via telehealth. Carriers responded here as well. The carriers adopted policies specifically authorizing coverage for services such as applied behavioral analysis, physical therapy, speech therapy, and occupational therapy, which weren't typically thought of as being, good services for telehealth prior to the pandemic. The carriers also focused on expanding telehealth services for mental health and substance use disorder services. That was a big focus. I would say that the biggest and most impactful accommodation was probably the coverage of audio-only visits, which, as the commissioner mentions, that's actually specifically excluded under Maryland statute. So the extent of coverage for audio-only varied by carrier, but every single one of them agreed to cover it in at least certain situations during the pandemic. There were also many requests to waive cost sharing to increase utilization of telehealth. The carriers agreed to do that during the height of the pandemic. As the utilization increased, that's when we began hearing the concerns from the provider community about reimbursement levels, because telehealth typically, as we've discussed, was not reimbursed at the same level as in-person visits. But in the commercial market, the carriers implemented policies that did provide for reimbursement parity during the public health emergency. So we continue to monitor the market conditions and the carrier actions. And as the pandemic subsided, some of the voluntary accommodations have been scaled back. Most notably, the cost sharing waivers started to expire in June and July. And at this point, there's only 2 carriers who are still waiving cost sharing for non-COVID related treatment. Although one other carrier has agreed to continue to waive cost sharing for behavioral health telehealth visits through the end of the year. A lot of the accommodations have also been tied to the scheduled end date for the public health emergency, but generally, as that's been extended each time, the carriers have then extended those accommodations also. So we continue to watch it, but again, these are all voluntary accommodations that we would not have authority to require the commercial carriers to continue to keep in place. And with that, I'll turn it back over to the commissioner to discuss the lessons we've learned during the pandemic.
Thank you, David, for that very thorough summary. So where does that leave us? So the feedback that the MIA has received about telehealth expansion has been overwhelmingly positive, especially mental and behavioral health services. However, as David just indicated, legislative action is necessary to require carriers to continue the voluntary accommodations that are desired by certain stakeholders and to initiate requested accommodations that were not made during the pandemic. So, for example, the policy considerations here are things about how does one handle audio-only consultations or communications through patient portals that do not even have an audio component, provider reimbursement rates, including parity, cost-sharing parity, provider licensing issues, consideration of telehealth coverage for specific services, specialties or modalities, and standards for what must be covered. And then uniformity in coding standards or more transparency and clarity by health insurers members and identifying covered services and coding standards. So those are issues that as this body takes them up, they would require legislative changes either to continue what carriers were doing voluntarily or to implement things that carriers were asked to do, but that were not implemented. I will also share with you that the MIA is evaluating the role that telehealth may play in achieving network adequacy and breaking barriers to treatment, particularly in the delivery of mental and behavioral health services. We will address telehealth as a consideration in meeting network adequacy standards in the revised network adequacy regulations that we expect to publish for initial public comment shortly. And the role of telehealth will be the subject of its own public meeting on network adequacy once we have gotten the initial public comments back on those what will be the proposed new regulations. And as we go through that process internally, we echo what you heard from other presenters about many of the practical issues that need to be considered, such as accessibility and availability of telehealth. So, infrastructure, broadband access, the availability of tools, technological expertise, the federal preemption issue. So how will the federal government address HIPAA privacy on a permanent basis? And also looking at achieving uniformity across markets, the commercial insured market, Medicaid, Medicare, and self-funded plans, because the lack of uniformity is a disincentive to the use of telehealth, particularly by providers. So with that concludes our formal remarks, and we are available to take any questions that you may have.
Okay. So Michael, I guess you're here in case there are questions, right? Okay.
Yeah, and just as a reminder, as everybody considers insurance legislation, feel free to send it our way for any technical feedback.
Okay, thank you. Delegate Saab has the first question.
Thank you, Madam Chairman. So my question, I guess it's a little bit more on the cost sharing issue that you brought up earlier. And from what I understand, there has been some miscommunication or misinformation. Patients are getting billed and getting co-pays that they are very confused about. Now, I know my understanding that the Attorney General direction and the law that we passed, that there's no cost sharing. And I'm wondering, and I think most of insurance companies have done a great job trying to fix it, but there's always few that fall through the crack. And I wonder if there's some way of communication that the Insurance Administration can let the carriers know, to let their members know that if they do get a bill, to call their insurance company and not the provider. It's creating some sort of, I would say, like maybe animosity between the providers and the patient. They think they're getting billed for something that they shouldn't be paying for. And so it's more of an ask than a question. If we can communicate better with the insurance companies and the patients or their members, so let them know if they do get a bill to call the insurance company and not their providers.
Absolutely. And David, do you want to address whether we have any data, what we've seen as at MIA from a complaints perspective on that issue?
Sure. And first, I guess, just to clarify, the cost sharing, I think that the law you referred to is likely referring to the coverage of the COVID testing and everything like that. So telehealth specifically, the law does not require the waivers of cost sharing, but companies have voluntarily done that for a significant amount of time. But yes, we've been tracking complaints, and for the longest time, we really got very few on this particular issue. We have gotten a few more recently, and typically, as soon as we've gotten involved, the carriers have reversed themselves, and it hasn't required formal action by us to issue an order. It's been kind of a administrative mistake where this has happened, and we are trying to, make sure that's not happening. But they have reversed themselves and paid for these claims once we've gotten involved. Like I said, we're just starting to see a little more now. We haven't before, but we can certainly, look for better outreach ensure the consumers are, like you said, going to the carriers and not necessarily to the providers.
So, just to follow up, so is there like a protocol or a process that the insurance administration is doing to communicate that message out to the members, or have the insurance companies communicate it to their own members?
So I can speak to our social media outreach where, we have on Facebook, on other social media devices, on Twitter, address the use of telehealth. So I will circle back with Associate Commissioner Joy Hatchett to look through kind of our stock of telehealth and make sure that we're addressing that particular concern. David, you may be better able to address what carrier communications have looked like.
I think from the carrier side, the one issue is either a provider or a consumer can, raise the complaints and grievances with the carrier. So when the carrier, I think information on their websites and things like that I've seen, does indicate, the contact information for these kind of concerns, but I don't know that it's necessarily focused on telling consumers to go to them, as opposed to like consumers or providers, can follow this process if there's concerns.
Thank you.
Thank you, Delegate. Delegate Kelly.
Thank you, Delegate Collison. Thank you for a great presentation. Thank you all for the work you've been doing. I know it's been really hard a few months, and we really appreciate it. And I know that carriers are not presenting today, but it's clear that they did a lot that they didn't need to do that I think helped people in Maryland as well. My question was specifically related to David's comments on the audio only. I think when you spoke, you said that 25% of the visits included video and 25% were audio only. Did you mean to say 75% were video and 25% were audio?
No, that was for one carrier in particular. Of the overall 50% of total visits, which were telehealth, of those 50%, 25% were audio and 25% were video. And that was one particular carrier.
One carrier, sort of half and half.
Half and half, exactly.
Do you have any rough data at all in terms of sort of what that breakdown looks like? I've been talking to my providers, and they say that seniors tend to like to do audio only. They're not comfortable with the computer maybe. Is it just the low income, or is it low income, rural, and seniors, or we just don't know yet?
For that, we don't know yet. And even getting this data from the carriers in a short period of time, they said they didn't really have the detail we were looking for. They rushed to get this, but I don't think they've kind of analyzed the data enough to have the kind of breakdown you're asking for yet. But I know it's something, we're looking at for sure.
Great. Thank you so much.
I don't see any other questions from committee members. I do have a question. As our first panelist said, this is a broader issue than just Maryland. I'm wondering, are we communicating with other states, particularly those closest to us, around, some policies that they may be considering, what they're looking at, just in consideration of all the options and possibilities that we might be looking at when we come into Annapolis in January?
So yes, Delegate Coulson, we are very actively involved on this issue at the NEIC, and we are coordinating both at the national level, and we also have fortuitously what we call our zone meeting, which is our geographic region, which is taking place next Wednesday, Thursday, and Friday. And telehealth is a very key component, and sharing ideas and needs will be part of that. And David, I don't know if you have anything to add to that, but we are very actively involved with our fellow regulators on this issue.
Thank you.
I don't have anything to add, but just, the experience we have in Maryland is consistent with what we're hearing from the other states. So we're all kind of looking at the same issues.
And you feel like there's an openness to actually working together to get some policies that will cross these, state boundary lines, so that we're, meeting that need to have the broader perspective. I mean, it's going to be important for us to know, kind of like where the bright lines are in terms of what our neighbors are thinking about, because, we want policy that'll fit in with the zone. So I hope that our zone members, colleagues feel the same way. So thank you for your work with that. And I don't see any other questions. Thank you all very much for this information. And we look forward to working with you on this. This is going to be a good part of our work, I think, together on the insurance subcommittee for sure. And I'm sure on health occupations as well. But as we move forward with legislation and policy over the 2021 session, based on what we've learned in this during this sort of emergency use of telemedicine. So we are going to move to our last panel of the day, and we're going to hear from Maryland Department of Health officials now, including the Director of Government Affairs, Mr. Webster Yee, and the boards of and commissions liaison, Kimberly Link. And again, we'll have time for questions and answer after their presentations. So Mr. Yee, I'm going to turn it over to you. Are we there yet?
Hello, Madam Chair, can you hear me?
There we are. Yes,
okay.
I can. Hi, Webster.
I managed to hit the triple mute. Madam Chairs, thank you very much. Webster Yee and Kimberly Link from the Maryland Department of Health. Mr. Gilbert, if I could get the next slide, please. Thank you very much. First, I think we are largely a me too on a lot of what our colleagues have already said today in today's meeting. And we've been working extremely closely with Commissioner Brand and the Insurance Administration and the Healthcare Commission and our fellow boards and commissions to make sure that Marylanders are able to access health care during the COVID-19 declaration of emergency. On the health department side, our efforts on the telehealth front have been largely focused in three areas. The first is we're an insurance carrier, and I mean to some degree through Medicaid. We've got about 20% of Maryland's population under our watch, with another about 20% under Medicare, which is federal. So our principal policy has been to ensure that Maryland Medicaid has been as aligned with our federal Medicare partners and their policies so that we can collectively cover the folks who are I think you can make a very good argument that they're some of the most vulnerable, both in terms of income and in terms of age. And so through both Medicaid and Medicare, we've been trying to ensure that the federal telehealth flexibilities are implemented within Maryland. The second part is, as you all know, the General Assembly did pass legislation in the 2020 session. We're looking through it and we're working with the various health occupation boards to make sure that if and when in the near future or hopefully at some point in the future, we are able to lift the state of emergency declarations, that we're able to then promulgate regulations to effectuate the General Assembly's intent in House Bill 448 and Senate Bill 402. And then the last bit is to basically either work with the governor's office and the respective health occupation boards to create Maryland-specific telehealth flexibilities. And that's largely occurred either through executive order and or departmental orders as the conditions warrant. And again, we had a flurry of activity in the first two and a half months, and then it kind of trailed off a little bit. And that goes with Professor Medtev's presentation earlier today. So if I could get the next slide, please. With Medicaid, again, I think MIA referenced this earlier. The federal government declared a public health emergency, and then they, as part of that, provided for two principal telehealth flexibilities. The first is they allowed non-HIPAA compliant technology to be used for telehealth services for healthcare providers. And then the second part is they gave dispensation for the use of audio-only services. And those two, of course, are flexibilities that we certainly haven't had and we're certainly exploring right now. The federal public health emergency is renewed for 90 days at a time. It was last extended on October 2nd, so we should be good through January or so. The state of emergency is every 30 days, and again, we've been renewing that declaration pretty much at the beginning of every month. The combination of the two really, I think, have developed the emergency and temporary framework that we have currently. We are, just yesterday night, CMS released new guidance on Medicare and Medicaid reimbursement, so we're still reading through that, and as we read through it, we'll develop more information. Next slide, please. Strictly speaking, on the Medicaid side, we're focused on ensuring that Marylanders who are Medicaid beneficiaries are able to access services. And I'm not going to read through the bullet points, but as you can see here, I think we are focusing on a couple core areas, such as home health care and allowing telephonic services through Maryland Medicaid. Next slide, please. And again, for your reading pleasure, we have immense amounts of information, provider updates, and guidance, and they're all available on our website with the relevant links here. Next slide, please. As you and I think the General Assembly know, House Bill 448 passed. The session, it was signed into law by the governor. It was an emergency legislation, and it largely replaced the previous telehealth statutory and regulatory framework. I believe the previous telehealth bill was passed, I think, 3 years ago, and then regulations were just put in last year. And then now with House Bill 448, we're going to take another look and see what regulations need to be put in to implement and effectuate House Bill 448. As the MIA noted earlier, it's very important to note that House Bill 448 does not permit telehealth health services through audio-only calls, emails, or faxes currently. The fact that that's law of the land has been to some degree superseded during the state of emergency through Executive Order 2411 issued on April 1st. And basically allows the health department to allow and authorize healthcare practitioners to deliver healthcare services through real-time audio-only calls, which we've done. And we're basically very carefully tracking it and making sure that we make tweaks as necessary to ensure that Marylanders are able to get health care. Next slide, please. And then with this, I'll turn it over to Ms. Link to discuss the Health Occupation Board side of things.
Thank you, Webster. I hope everybody can hear me okay. My neighbor has decided to mow his lawn at this exact moment. So, so as Webster was saying, the department has really tried to be as flexible and responsive to the needs of the boards as this, not only do we have the enactment of the telehealth bill, but then immediately on its heels was COVID. So the health occupation boards really had to jump into this rather quickly and soon discovered, some of them, that their current regulations regarding telehealth may not be adequate to suit the needs during the pandemic response. So for example, the Board of Professional Counselors and Therapists, their existing regulations for teletherapy did not include alcohol and drug trainees. Under their current regs, alcohol and drug trainees weren't permitted to use teletherapy services because they were the entry-level credential, and they were excluded from that. However, due to the pandemic response and input from stakeholders and licensees, the board was able to hold an emergency meeting to allow alcohol and drug trainees to make use of those services, because especially in the substance abuse area, they are an integral part of the workforce. And the secretary did issue an order allowing alcohol and drug trainees to actually use teletherapy services where they weren't able to before. Also, a big issue that came up with that particular board was for students. So if a college student was receiving mental health services at their school, say in California or Arizona, as part of their college experience, and they were forced to come home during the pandemic, they were in a situation where they really needed or wanted to continue with their counseling services, but their particular counselor in that state was not licensed in Maryland. So the board asked, and the secretary complied or granted an order that said that allowed out-of-state counselors to continue with their existing clients who have returned to Maryland during the pandemic. So that would allow for access and continuity of care, which is very adaptive, and the board was especially appreciative to the department for that. Same goes for the audiologist, speech language pathologist board. They had similar issues, which the department was responsive to allow continuity of care, even for children perhaps who were receiving services, it's speech language pathology services in Maryland, and then perhaps had to go back home or actually live across state lines. So that enabled continuity care as well. Not a telehealth issue, but Morticians Board is an example where the department worked with the board to waive the practical exam requirements for a mortician's license, because in the days of COVID, a practical examination was not advisable. So next slide, please. So the department took an informal survey of the 22 health boards and commissions. And just briefly, I'll hit the highlights here. The biggest thing that happened right away was the inquiries received by the boards from providers, from patients, clients. For example, who can actually give these services? Where must the client be located? Do I have to be in Maryland to receive services or to provide services, for example? Many were searching for guidance on compliance with the technological requirements, meeting HIPAA requirements, what platforms can they use? What you would expect when someone is suddenly a provider who may not have made great use of telehealth services to start doing so in a sudden way, naturally they have a lot of questions. So the board's report receiving a great deal of calls and emails on that issue. It has slowed down quite a bit, but initially there was a great deal of confusion. The only board that has received complaints, disciplinary complaints regarding telehealth thus far, I'm sure that will probably change over time, it's been the Board of Physicians. And I've bullet pointed what information they've provided to me regarding the nature of some of those complaints. And by far, the greatest number of complaints so far have been about out-of-state practitioners prescribing controlled dangerous substances to Maryland patients. Also, telemedicine companies and physicians prescribing high-cost durable medical equipment, prescriptions, and controlled dangerous substances without a Maryland license. Prescriptions issued without a physical exam or an existing patient relationship has been the topic of complaints. Also, there have been complaints about Maryland licensed physicians who are supervising out-of-state physician assistants who are not licensed in Maryland, and those physician's assistants are prescribing to Maryland patients. And then the last category would be more along the lines of what you would expect with the use of technology. Professional conduct issues, what's appropriate, what's not appropriate, what is professional conduct in terms of having these actual sessions via camera or audio, practitioners muting patients or their family members, patients being denied telehealth visits, practitioners either not showing up or missing appointments or being late. So, those are things that are probably worked out more over time. However, it seems like the most pressing issues presented so far to that board were about the out-of-state practitioners. It's essentially become an unregulated area that the board is forced to confront at this point. So I'm happy to take any questions.
Thank you very much, Ms. Link, Mr. Yee, for your information. I have a number of questions that have come up. Delegate Lewis, Robin Lewis, please.
Thank you, Madam Chair. Thanks, everyone. I appreciate the Department of Health presentations. My question is to Ms. Link. I was pretty surprised to see those consumer complaints. I'm wondering if, I mean, it just sounds rather disturbing, and I'm just trying to get context. Are those types of complaints similar to the ones that you might have seen pre-COVID for a typical face-to-face clinical visit? Is this within the range of normal, or is this extreme and unusual?
Well, it's unusual in that it's, the question I posed to the boards was complaints received regarding telehealth. And I think with the increased use of telehealth services, we're getting a different, the boards are getting a different strain of complaints.
Does it seem overwhelming to you? Like, is this a deluge of complaints, or does it seem like a normal flow to you?
I would have to defer to the Board of Physicians. I'm not sure what their normal volume of complaints on a monthly basis is. I know that this is at least 15 to 20 complaints they've received so far, and the other health occupation boards haven't received any yet. So, you know, there's a lot that goes into a complaint. For anyone can file one, first of all. And, you know, but I'm not sure of the Board of Physicians' normal volume. I can look into that and get back to you if you'd like.
And I guess my last question would be, what are the remedies that the Board of Physician puts in place? Do they apply their typical, you know, investigation, resolution sorts of procedures, or how does that work?
Without having them here to answer that, I can pretty much say that I'm sure they follow the same procedures they follow for any other type of complaint. All boards have a structure in place whereby a complaint is received and reviewed and investigated. Each of the boards goes about it slightly differently, but I'd be happy to get in touch with the Board of Physicians and give more details on that if you'd like.
That would be helpful. Thank you so much. Thank you.
Thank you, Delegate. I have a question from Delegate Sample Hughes.
Good morning, and thank you, Madam Chair. Ms. Link, this question is for you. Well, first, I'd like to say thank you all that have presented here today and the updates. Very much appreciative of the teletherapy information regarding continuity of care and ensuring that our citizens are getting what they are in need of. The question is regarding the durable medical equipment. I know you raised that as being a complaint. Are you referring to the fact that companies are charging more for durable medical equipment? Because I know we have a lot of individuals that are, you know, wanting to or actually able to move from, you know, nursing home to a community setting, and they are in need of some durable medical equipment. But what seems to be the exact complaint?
Delegate Sample Hughes, I'm only familiar with the information that the Board of Physicians provided me in response to my request to speak to you today. So I don't have the details of the actual complaints. But I'd be happy to find that out or have someone from the board be in touch with you to give you more context around what might be involved. Disciplinary complaints and matters are normally not disclosable, but I'm sure they'd be happy to provide you with general information about the nature of the complaints that they're receiving.
Okay. Yeah, if you could, I would appreciate it, because I just think, you know, a lot of our citizens need those durable medical equipment devices, and they are getting charged to Medicaid. So I'm just curious, is that another area where we need to look at to ensure that we're not paying more for items that we are having to use for our citizens? But much appreciated for researching that a little bit more.
No problem.
Okay. Thank you very much. Thank you, Delegate. Delegate Kelly.
Thank you. Thank you, Delegate Collison. Thanks for the great presentation, Kim. And I don't know if this is a question for Kim or Webster, but I know that particularly, you know, we do health occupations and long-term care, and I was really interested in your your presentation on sort of the different things that the boards have needed to adapt via telehealth. One of the things we didn't talk about, but I think is kind of connected with telehealth, is actually the proposal before the Board of Nursing right now for the online delivery of the curriculum for the CNAs, which I think is also really important when we talk about the healthcare workforce. How are we getting the workers trained that we need? So as we look at long-term care facilities, I know that that's one of the things we've been hearing the most is we need more licensed CNAs to provide this care. There's a workforce shortage. And I know that the Board of Nursing has been working to try and get that curriculum. I don't know if they're trying to get it approved, but they're coordinating at least with the interested stakeholders to try and modernize online delivery of that kind of curriculum. And I'm wondering if that's something that's happening across the boards, if we've been hearing from other boards about finding ways to alternately, get a more qualified workforce through virtual technology.
Webster, do you have any additional information on that, or?
Sure. So with respect to the Board of Nursing and the online GNA, CNA issue, Delegate Kelly, as you know, the Board of Nursing has been working through it with actually, I think all three of the principal nursing home associations. I think they're thinking very strongly about it. It's a question of, I think for them, what is the appropriate level of continuing education and in what form, and they've been obviously working through it along with an associated issue with the Maryland Higher Education Commission. So I know that they've been in a correspondence loop with you, and then we've asked them to kind of walk us through, I guess, the differences, if you will, on what are the consequences of certain actions. So we're all taking a look at it, and then the department, as Ms. Link pointed out in her presentation, we've been really trying to, whenever possible, solicit the clinical guidance from the boards, since they're regulated by their own peers. And so based on their recommendations, we'll try to take next steps forward. But that said, as you noted very correctly, we have an issue with our nursing homes, and we want to make sure that they are adequately staffed, that the residents are protected, and that, especially in light of COVID right now, that folks are taken care of. So we're all taking a very careful look there. And then with all of the boards, I think there is definitely a look. They're constantly in this process of reviewing their regulations, having internal board discussions, and as we see proposals to modify each board's different continuing education requirements and frameworks, we're just saying, hey, let's have a conversation and see what's the best fit. And most of the regulations or most of the continuing education items are in regulations and not necessarily in statutes.
Go ahead. I'm sorry, with respect to the other boards, I didn't specifically ask them about their efforts in terms of increasing workforce. But I can tell you, I know with the Board of Professional Counselors and Therapists, for example, that board works closely with the community colleges. And I know Baltimore County Community Colleges been awarded grants, and they are essentially making it free for people to come to school at their community college and get a certificate in alcohol and drug counseling, for example. So I know that it will depend on the occupation involved, but I know the boards are keenly aware of workforce shortages in certain areas and are working with stakeholders to try and increase that workforce.
Super, thank you. I think maybe I didn't ask my question as clearly as I wanted to, but I guess it hadn't occurred to me the parallel before this whole meeting between all the work we're doing to expand access to care using telemedicine and sort of the work that we also need to be doing to expand access to workforce training using technology. So I just wanted to connect the dots for folks, and I appreciate the work that all the boards are doing looking into that.
Well, and on that note too, it's funny, I hadn't thought about that either, but I know many of the national exam administrators have moved to an online format instead of an in-person testing, which has greatly enabled people to continue to get licensed, whereas there was a lull at first because the testing centers were closed. Many of the testing administrators have adapted to an online format, which has been very helpful for a lot of professions.
Thank you so much.
Yeah, great, thank you, Delegate. Delegate Krebs, I'm sorry I missed you in the queue here. You're up now.
I'll forgive you. Thank you very much.
Thank you.
I just wanted to go back to when Dr. Atif at the very beginning of this briefing spoke about the feds are looking at limitations on state professional licensing and pushing for reciprocity against state lines, giving more options to patients. And it seems like this issue is not going to go away. And I wanted to ask maybe Kim or Webster, what are we doing comprehensively to look at this issue, and what are other states doing? And I don't know if a group like NCSL or something like that is bringing these issues up, but this is an issue among all 50 states, and especially our small state with a lot of borders. So is there energy on that? And I think we're going to have to really look into this as we've accelerated the path toward out-of-state licensure.
Well, fortunately, I think there are 2 or 3 bills coming before you this session for interstate compacts for several of the health occupations. There's occupational therapy has one in the works, speech language pathologists, and professional counselors. There already is in existence the physicians, nursing, physical therapy. So I think Maryland is really on the advanced side in terms of being open to interstate compacts. I think that's the best method of moving forward at this point in terms of reciprocity and allowing portability of practice, especially for military spouses and states with many borders like Maryland.
That's good. It sounds like the Board of Physicians, though you mentioned, is the biggest, has the most number of complaints, and that's going to be the biggest nut to crack. So I hope that we focus on the Board of Physicians and that type of reciprocity.
Well, and the challenge too is, as you know, the board's mission is to protect the public. So the issue of having a provider in another jurisdiction raises issues of enforcement, and how do we protect the citizens of Maryland from out-of-state practitioners who may not be acting in their best interests.
I didn't say it was going to be easy, but thank you.
Thank you, Delegate. Delegate Bagnall.
Thank you very much, Chairman, and thank you for everyone for your presentation today. I just had a follow-up question actually on the heels of Delegate Sample Hughes, just asking if you could get us a little more context around the complaints around prescribing without without an in-person or without a connection, because I know we've been threading the needle very carefully in terms of telehealth for behavioral health, in terms of telehealth for reproductive access. So if we could just get a little more context for if there's a particular arena where those complaints are coming, so that we can look at.
I will do that. Make sure that the committee gets that information.
Thank you so much.
Thank you, Delegate. And I'm going to go a little bit further in that same area, because these complaints can be really helpful to us in looking at policy. So we really need some very clear information about it. So I need information like the actual number of complaints and the category and where they fit. And I do need information about where they're coming from. I don't need the person's name. I need, is it a physician? Is it any kind of provider? Is it a consumer? Where is the complaint coming from? And how does that compare to pre-COVID? So I think, and we need it not just for physicians, but other practitioners as well. And there may be other things that I haven't thought of as we've been talking, but I think it's going to be really clear, really necessary for us to make sure that our policy covers the things that we know are happening and that we're learning from this current experience. So, perhaps we can work together on how to create the questions that will get us the information that we're going to need as we think about this.
Absolutely. And what I took away from the Board of Physicians points to me was the issue of unregulated out-of-state providers and protecting the citizens of Maryland, especially where controlled dangerous substances are involved.
Mm-hmm. Right. And what I think I heard in our first presentation is this is a national issue. Yeah. Right. So we need to get the information we need to make the good policy. I really thank the two of you for your information. I don't see any more questions, so I am going to turn it over to Chair Kelly.
Oh, excellent. Just in time. I am supposed to be closing the meeting today, so definitely want to thank all of the presenters. Really wonderful information today. Thank the committee members for all of the work that they have done in their thoughtfulness and the work we're going to be doing in the coming months on these issues. Especially thank the committee staff who helped us with this. Aaron, Lisa, and Lindsay all helped pull together this meeting. Special thanks to Dylan Goldberg for handling all of our technology and our presentations and keeping us on task. And of course, Delegate Cullison for doing an exemplary job of chairing this meeting. And we were joined today by our extraordinary chairman and vice chairman of our committees, Chair Pendergrass and Delegate Pena Melnick. So thank you for joining us. Just in closing, so that we know what the rest of the what is coming up, the legislature's COVID-19 response work group is going to continue to address a variety of issues related to the topics and jurisdiction of this and the other committees. As of right now, at the direction of that work group, the Health and Government Operations Committee has scheduled a series of full committee and subcommittee briefings. So for the public's information, you can monitor the Health and Government Operations Committee hearing schedule on the Maryland General Assembly website for updates. And for committee members, you have previously received a list of the meetings and the dates from the committee staff and will continue to receive updates as necessary. The next meeting on our schedule will take place on Wednesday, October 28th at 1 p.m. That is the Government Operations and Facilities Subcommittee, and it's going to receive updates from the University of Maryland Medical System, Open Meetings Compliance Board, PIA Compliance Board, and the Public Access Ombudsman. So that is what is coming up next. And with that, I think we conclude the meeting. I hope everyone has a wonderful rest of the day, and thank you again for everything that all these folks are doing to improve the lives of Marylanders. Anything from you, Delegate Cullison? Perfect. Bye.